so we don't. Questions?
Hello, Mrs. Stop.
Hi.
So I have, do you advise us to have a marking book since it's cover, a lot of part of the.
Started from the booty.
I'm sorry, say that again. Armel, is that how you say your name? Armel?
Yeah. I'm asking if you advise us to have a marking book.
The McKinney?
Yeah.
Gosh, I wouldn't make you buy something. I mean, it's a huge book. This is what it is. If it's a good maternal child book, I'm not really sure why we didn't, but I guess we have the concepts and you have the med surge, the IGGI and the ATI. So I don't know that you absolutely need it, Armel. It's a lot of money to spend on that.
Okay, thank you.
Okay.
Yeah.
Anyone else? I'll go ahead and start taking roll. Armel, I know. Grace?
Here.
Jonathan?
Here.
Lydia?
Here.
Maricruz?
I'm here.
Nozomi?
I'm here. Good morning.
Good morning. Claudia?
Here.
Emily? Hi, Claudia. Emily?
Yeah, I'm here.
Okay. Francesca?
Here.
Margaret?
Here.
Francisco?
I'm here.
Monique?
That's Miss Dupree.
Oh, thanks. I'm like, oh, wait, that's not Loida.
Here.
Adamir.
I'm here.
Okay, Alfreda.
Present.
Alexander.
Here.
Milanith.
I'm here.
My. Gosh. Hugo, I saw. Myra.
Here.
Christine.
Oh, I'm here, Miss Dorp.
Okay, David.
Here.
Amarani.
Here.
Okay, Jasmine.
I'm here.
Roberto.
I'm here.
Whitney.
I'm here.
Vanessa.
Here.
Raul.
Here.
Aaron.
Here.
John.
Here.
Shannon.
Here.
And let's see, Buena.
Here.
And Brittany.
Hi.
Hi. And Samantha.
Here.
Isaac.
Here.
And let's see, Nicholas.
Here.
Amanda.
Here.
Abram.
Here.
Crystal.
Here.
Selena.
Here.
Kelly.
Present.
Marco.
Here.
And Kenya.
Yeah.
Okay, great. All right. So I posted in the module your student version. So I know some people like to take notes on a PowerPoint. Is that something you guys that you feel is beneficial?
Yes, absolutely.
Yes. Okay. All right. And the next question is, so have you done the real life scenarios before on ATI? Did you do them last semester?
No, we didn't.
Oh, you didn't, okay. So, there's a few ways that this can be done. The way that I kind of envision it today is I'm going to do the short PowerPoint, kind of short and sweet on fluid and electrolytes, which I'll touch base in a minute with that. But and then I'll put the real life scenario up, and we'll go through it together. And then we'll stop. We'll answer the question. We'll talk about it and move through it. Okay. The other point to that was, so last semester, I know this is all really different from when I taught first semester. Did you go through fluid and electrolytes? Because I know in clinical we touched bases on it. Yes, okay. Okay, good. So people feel like they have a base for fluid and electrolytes. Believe me, guys, it's something that's an ongoing learning thing. So I'm not saying, do you know it 100%, okay? The nice thing about the way the new curriculum is that we'll keep touching base on these different concepts each semester, and you get to view it with a patient in a different situation. So the focus of the fluid and electrolyte balance today is going to be on fluid deficit, fluid and electrolytes deficit. And we're really going to focus more on, well, today it's the child with gastroenteritis, but also you could fit the woman with hyperemesis gravidarum. All right. And so I think you read some, ATI has actually a nice chapter on that. And if you need more information, I can get you more information, but we're going to focus today on the child with the gastroenteritis. That being said, in your exemplars, there was the postpartum hemorrhage.
Ms. Thorpe?
Yeah.
Sorry, what ATI book has the information?
Oh.
If you don't mind.
No, not at all. I think I just saw it in the maternal, this is the nursing care of the child, but the maternal, the ATI books like this, but it's on maternal health. Do you guys not have that one?
I don't have my books yet, but I have my VM books. That's why I was asking.
Yes, we have
Okay.
one.
Okay. Did you find it in there? You found it, didn't you?
Yes.
Okay. Just want to make sure we're on the same page. Because the other part that I go by is still my McKinney book, but you know, I right now you're not going to need that, okay? So anything from last semester on fluid and electrolytes that you all covered, that you felt like we still were struggling with that? No, Kelly, you're fine with no McKinney. Okay, I don't want to insinuate that you need another book, because I know you already have spent a ton of money. Okay.
Well, for me, the main thing I'm still struggling with is just like remembering like hypo versus hyper symptoms for all the various imbalances. So
Yeah.
I kind of got it, but it's just kind of like constantly learning for me.
Exactly, Aaron. And what I find is, and we'll go over some of those when it's related to the child. What I find is once you start kind of coming up with a system to memorize it, I think it's going to become easier. Okay. For me, I'm a visual, hands-on, show me what that looks like person. So I think the more you're in clinical and the more you get to attach, oh, that's what a person looks like when they're hypovolemic. And that's what a person looks like now that has fluid excess. And now our job is to pull that fluid off, out of their system through whatever medications or whatever they decide to do. Okay. So let me go ahead and start with. So I was trying to figure out the best way to start on, because I don't want to run out of time for, let me move this over here. I don't want to run out of time for us to do obviously the ATI. So let's go ahead and get started here. And I think if someone can tell me, let's say at 11:50, if you wouldn't mind. Can someone good at taking time?
Yeah, I'll
I'm
remind
gonna
you.
start. Okay.
Okay, who is that? Hugo or Francesca? Okay,
Francesca, just be my backup because I might forget.
I know.
Okay.
All right. Oops, let me make sure you can see my screen. All right, everybody can see my screen, right?
Yes.
Okay. All right, so let's get started. So this is going to be on the fluid electrolytes. And I know I put this on every lecture I do, but these are the learning outcomes for the week. So you can see that really our focus is one, imbalances across the lifespan. And our exemplars this week are, like I said, these. The hyperemesis gravidarum, fluid loss in the young child, and postpartum hemorrhage. We're going to look at some about the fluid excess, but I really kind of focused more of this PowerPoint on fluid deficit. All right. And then focusing on what we need to do as nurses in order to, in each one of these cases, but specifically we're going into the child with gastroenteritis. So definition of fluid and electrolyte, basically this is in your Giddens book, right? That fluid and electrolyte balance is the process of regulating the extracellular fluid volume. So ECFV, body fluid osmolality and plasma concentrations of electrolytes. Again, these are, remember when you look at, and I think I have this slide up a couple of times, and I think it just brings home exactly what concepts or areas that fluid and electrolytes actually affects. You can see from nutrition, mobility, acid-base balance, all of this, okay? The scope of fluid and electrolytes are from, you can have, so electrocellular fluid volume. And then this here goes down to the osmolality. So here is where we start talking about sodium, right? And what the osmolality, normal osmolality would be optimal. And then here they're just saying, this is in relation to potassium. So obviously you can take every electrolyte, sodium, magnesium, potassium, any of these, and put it on a spectrum. Normal physiological process is, this has to do with water regulation, water distribution, the role of fluid in the body, electrolyte regulation, electrolyte distribution, and physiologic role of the electrolytes. And I think, who was it, Aaron, that was saying, just understanding what high and low, I think once you understand the physiologic role of the electrolytes, and that's going to be something that's ongoing that you'll learn. Once you understand that, it's going to be easier to say, oh, that person's low in this, or that person's high in this. The two main ones you really want to focus on is your potassium and sodium. And you pretty much should know that low and high of those two things, just kind of in your head, just so you look at a report and you don't have to know that, oh, that's I need to look up what that parameter is. This is a slide, and I think there's two slides that kind of bring it home a little more. Water content in an adult constitutes 50% of the adult's body weight. The older adult does have less lean muscle mass, 45 to 50% compared to the adult. So this is the older, oops, oh my goodness. Because the older adult has less body mass, they can also get put into, they're at higher risk for dehydration. And over here, the infant, they have a high part of their fluid, their body weight is water. So they get into trouble quick, get hydrated. So that's why you can see in this picture. So this is kind of just another picture showing you the same thing. And I'm sorry, I used McKinney on this. So this is just showing ECF is lost first when fluid loss occurs in the child, okay? The intracellular compartment is more difficult to dehydrate. Because approximately 50% of this ECF is exchanged daily in an infant, dehydration can occur very suddenly and rapidly if fluid intake is inadequate. So you have to be really a child comes in, a baby, let's say a baby, and they have been vomiting, not really taken in any fluids. You ask the parents about their urine output. Those are all signs that this child's going to get into trouble quickly. Here's a graph. Because the higher percentage of water in the ECF, infants can lose fluids equal to their ECF within 2 to 3 days. So again, just bringing home that part of, we have to really pay attention when this age comes in with problems. The other things is infants are less able to concentrate urine because they have an immature renal system. Their kidneys are immature. Infants have a rate of peristalsis than do older children, and infants have an immature lower esophageal sphincter, which makes them more prone to the gastroesophageal reflux, which can lead to dehydration quicker. Infants also have a harder time compensating for acidosis because their decreased ability to acidify their urine. Infants and children have a higher metabolic rate or turnover of water relative to adults because they have because of their high metabolic rate. In comparison with adults, infants and children have proportionally greater body surface area in relation to their body mass, which results in greater fluid loss through their skin and through their body, through their gastrointestinal tract. So in summary, body fluids across the lifespan, the younger person has a greater percentage of water that contributes to their body, and a greater proportion of the body weight is located in the ECF fluid compartment. So when we calculate calculation of fluid gain or loss, if a patient drinks, 240 mLs or 8 ounces of fluid, their weight gain would be a half a pound. So basically what we need to remember is you can, and this is really important, taking care of children especially, you can translate. So what they put out can translate in, I mean, I think about when we weigh a diaper, and I'll go into this, and it's 30 grams, that translates to 30 mLs or 30, it translates back and forth. I know I'm not explaining that very well. If fluids are lost, here's a way to make it real. So if an infant is 11.8 kilograms or 26 pounds, remember 2.2 pounds per kilogram, 65% of the body is water. So the percentage of ECF in the weight is 30%, which is 7.7 pounds or 3.54 kilos. So is it a good thing to lose, for this toddler to lose 7.7 pounds of from his body weight of 26 pounds?
No.
No, that child would be in serious trouble, right? Whereas if you have an adult, that's 70 kilograms or 154, 60% of the body is water. So the percentage of ECF in weight is 20%, which is 30 pounds. 30 pounds of 156 pounds is lost. That's still a lot. I wish I could lose that much weight. But it's not, this adult is going to be okay with that, most likely because maybe this is an adult that they purposely are trying to get him to lose the weight through fluid. So recognizing the causes of fluid and electrolyte imbalance. Remember to take the history. And I put red flags in my head. This is how I think of stuff when I'm taking a history on sorry, I keep looking over here because I had to move you guys all over there. History taking is the first time you see the patient. Usually it's the I know you went over this last semester. It's the time where you're visually looking at this patient. You're asking, in this case, it would be a parent. You're asking about how long, if they've been vomiting, diarrhea, what did the diarrhea look like? Any kind of history of kidney or heart problems already. And if you're talking to them and they're just giving you vague kind of symptoms, those are all red flags. Those are possible symptoms of fluid and electrolyte imbalance, although they're specific, but you have to write them all down and just take those in. In Giddens' book, they go over a huge amount. If you go through, and I don't know if I have my Giddens' book right here, but in the tables, they go through each one of what fluid imbalance looks like in a client. So there was no way to even list all of those right here, and you guys can go back to those pages. It's tables 8.1 and 8.2 in your book. Let's see. So Clinical findings associated with electrolyte imbalance are dependent on the type of imbalance, obviously, and severity. So consider the functions of the following electrolytes. What does potassium, when you think about potassium, what do you think about?
Cardiac
I think
Cardiac, okay. Anything else?
Dehydration.
When you think, oh, if they're low on potassium, they must be dehydrated. Okay.
I think cramping.
Cramping, good. What's the low parameter on a potassium? Do you remember?
Lowest is 3.5
Yes.
milliequivalents per liter.
Yeah, I always think 3.5 to 5 is kind of in my head parameter. How about sodium? What do you when somebody's low or high on sodium?
Water retention.
Mostly we see low, right?
Also cardiac, and then you're looking for swelling.
Yes. Yes, perfect. So what is your parameters on sodium? What do you think about?
135.
135. I think the upper for me is about 145. Am I right? I think it's 145, but 135 is kind of that low that you're looking at. And how about calcium?
From what I remember, it was 8.5 to 10.5, but again, that varies between labs.
And what are we worried about with calcium, a low calcium?
Osteoporosis is a big one.
Anyone else?
Vitamin D deficiency.
Yeah, that's good. Yep.
Muscle contraction.
Yep.
I would say heart contractility.
Yeah, if you have problems with calcium, not as much as potassium, obviously, but yeah, good. So some of the diagnostic tests that we're going to do, and this is across kind of the lifespan for whatever's going on with this patient, you would want to get serum levels on the osmolality, sodium, potassium, calcium, magnesium, and ECG. And I think we already kind of covered why we would think about an ECG because of how these affect the heart muscle. So let me just, I'm trying to, where are we at time? Let's see. Let me just go through the rest of these slides, okay? So at least you have, this is going to talk about a little bit about nursing interventions and the collaborative interventions that promote fluid and electrolyte balance. Remember, and this goes back to why we had you work on the methods sheet for the gastroenteritis. It just makes you think about what you have to tell these parents. But here with primary prevention, it's basically covering, you know, you have that brand new newborn, or you have a child or someone with a healthy person that's in your office or that you're assessing. And the basic teaching is just that anything that you can tell them to minimize the risk that they're going to get into trouble if something does start to happen. So if there's vomiting and diarrhea, what the person can do if that happens to help. Then secondary, basically they're saying that they don't screen people for fluid and electrolytes as for secondary prevention. It's basically, it might be that, let's say, you have trouble with high blood pressure. So they do an electrolyte panel just to see what your sodium and potassium levels are. Because remember, thinking about potassium, some medications also can affect those levels, especially potassium. The clinical for collaborative interventions, you would treat the underlying condition. So basically, there's nausea and vomiting. Okay, medication to help with the nausea and vomiting. Water replacement therapy, we always want to look at oral replacement first, right? It's going to get absorbed through the GI tract. It's just one of those things that you want the oral replacement first. If we can't, we'll go to the intravenous fluids. If they need electrolyte supplement, but only if they need it and we know they need it, you would encourage the potassium, sodium, magnesium, and calcium. And then any kind of medications like diuretics, insulin, and vasopressin. Just curious, are you starting to, in farm, have you addressed any kind of like nausea medication, diuretics? Have you addressed that this semester yet?
Not yet. I think
Not
we're
yet.
gonna get those later on in the semester.
Okay. But you saw that last semester, right? I'm sure you saw IV fluids with potassium in them. Blood pressure medications. Did you give potassium, like oral replacement potassium?
I always give potassium where I work.
Same.
Okay. Okay. Where do you guys work?
Well, I used to work, but I gave up my job for the school.
Oh,
But yeah, I was
So-
giving oral potassium.
okay.
I work
Okay.
at 2 places. One's in Gilroy, one's in Morgan Hill.
Wow. Okay. Okay. So some additional interventions, and if we go back to that slide that I was talking about, 2.2 pounds and how much fluid loss and how much fluid gain, that's daily weights is the #1 assessment you can do to understand where the patient is on fluid loss and fluid intake. Does that make sense? I keep looking over there because we're all over there now. Does that make sense?
Yes.
So if you doing daily weights in the morning is extremely important assessment for the doctor to know, okay, do I need to order some more Lasix for this person? Or wow, the baby has lost, another 2%. We may need to start an IV, or we need to maybe do some more interventions for the child. Monitoring fluid INO, and comfort measures, safety, oral hygiene, and then patient teaching. Told you that slide was there again. So when we talk about fluid volume imbalances, again, you have to replace the water and the electrolytes through orally or blood products or balanced IV solutions. Why would we need to give blood products? What situation would we need that?
Hypovolemia is the biggest one.
Okay, but couldn't we do hypovolemia? Couldn't replace it with like a normal saline or some sort of isotonic solution?
It's
I
to
would
not
say-
throw off the hematocrit, right?
Pardon me?
Is it to not throw off the hematocrit? Because by just adding fluids, we're not adding any red blood cells.
Right. So do you think, so blood products, sometimes for hypovolemia, if the cause is from blood loss, like postpartum hemorrhage, then the most likely placement is going to be an O negative blood, or type and cross match blood for this person to replace that. Because if you just give packed red blood cells, you're not really helping with replacing volume, right? So whole blood is what they would look at. So here is fluid volume excess, and I only threw this in just because, you know, sometimes when you're thinking back and forth, understanding what's going on. This has to do with, and it's called hypervolemia. So fluid volume excess may result from excess intake of fluids, abnormal retention of fluids, like someone with heart failure or renal failure, a shift of fluid from the interstitial fluid into the plasma fluid. So now you've pulled this fluid into the plasma fluid, and now all of the intravascular volume has gone up. Weight gain is the most consistent manifestation of fluid volume excess, which we've already said. Clinical manifestations is usually related to CNS changes. They include headache, confusion, lethargy, edema, peripheral edema, jugular vein distension. Remember that? Bounding pulse, hypertension, difficulty breathing, crackles in the lungs, pulmonary edema, muscle spasm, seizures, and they can go into a coma. Interprofessional care would be managing the fluid volume excess by treating the underlying cause and removing that fluid without producing abnormal changes in the electrolyte composition, right? We don't want to pull out the fluid out of their system and lose potassium and sodium and all of the good electrolytes. So they're going to look at diuretics and fluid restrictions as the primary form of therapy. They're going to look at restricting sodium intake. If fluid excess leads to ascites, do you remember what ascites is? Do you remember seeing a patient with ascites?
Yeah, it's when fluid builds up where it shouldn't, like in the abdomen.
Right, right. So if it leads to ascites or pleural effusion, they might do the, I don't know if anyone got to see one, an abdominal paracentesis or a thoracentesis may be necessary to pull that fluid off. Usually it's that the person's so uncomfortable they can't breathe. Fluid volume deficit can occur from loss of body fluid. So here we're talking about diarrhea, vomiting, hemorrhage, polyuria, which is overabundant of urine output, inadequate fluid intake, or a plasma to interstitial fluid shift. The term fluid volume deficit and dehydration, they really aren't the same. Dehydration refers to the loss of pure water alone without corresponding loss of sodium. So the clinical manifestations of somebody with hypovolemia would be restlessness, drowsiness, lethargy, confusion, postural hypotension. What is that? Do you remember?
It's when you stand up and your blood pressure drops.
Yes, or just even sit up. Tachycardia, tachypnea, so increased breathing, weakness, dizziness, weight loss, seizures and coma. This is where skin turgor, capillary refill, and urine output are all, well, urine output is decreased, skin turgor, and capillary refill. I don't know that, well, would be decreased. So capillary refill would be longer, right? Because there's not as much blood in the system or fluid in the going around in the system. So you do the capillary refill assessment and it would be 4 seconds, maybe. So managing fluid volume deficit involves correcting the underlying cause, like with hypervolemia. In mild losses, you can just do oral rehydration. If it's more severe, we may have to use blood products or balanced IV solutions such as normal saline or Ringer's lactate. Here is just a kind of a side-by-side between hypovolemia and hypervolemia. A patient with hypovolemia has or is at risk for deficient fluid volume, decreased cardiac output related to the ECF losses or decreased fluid intake, and risk for impaired oral mucous membranes related to fluid volume deficit. The patient is at risk for hypovolemic shock if it's not corrected. And with the patient for hypervolemia, these are, obviously fluid volume, impaired gas exchange, risk for impaired skin integrity, because with the ascites, and I don't know if you've gotten to see it, they can get stretched and they can start, their skin can, what do you call it? Just break. You can have skin damage. Activity intolerance, disturbed body image, and the potential complications are pulmonary edema and ascites. I realize that we are really going to concept-based, well, we really are at concept-based goals or, so like I would say, what's an example of how to write a goal now related to your concept? Could you say,
increase fluid intake?
Related to fluid and electrolyte, fluid balance, potential problem. How would you guys put that? You know what I'm asking?
No,
Do you remember on our sheets, huh?
Can you rephrase or repeat?
Yeah, so do you remember last on your clinical papers on your when you do your whole paper, you do your nursing goals and
Like a care plan at the end, what is your goal? Is it what you're asking?
yeah, so what would be your patient problem? How would you put that?
Maybe at risk for fluid volume deficit related to vomiting or diarrhea.
Perfect. Yes. Was that Amanda? Or no, it's Shannon. Yeah, that was good. So just try to keep thinking in those realms, taking it back to the concept, okay? These will give you ideas, but you got to relate it back to the concept. Nursing management, again, daily weights, know what their intake and output is, review their lab findings, and and understand that for cardiovascular care, you're looking at, you know, taking their vital signs, weighing the patient. What else? Lab results, you're looking at serum osmolality, BUN, sodium, what is their hematocrit? Because remember, and I think, was it, who was that said that, Hugo or Abram, that said something about the hematocrit? If their hematocrit is normal and you know they're hypovolemic, is that a kind of a valid, it could not be a valid hematocrit, right? Or if they're hypervolemic and your hematocrit is low, they could very well have a normal hematocrit, right? It's just that their hematocrit is being diluted. I know I'm probably throwing too many things out at once, huh? So understanding when you do your assessment, knowing obviously their blood pressure, if we have a central venous CVP line in, trying to get a pressure off that, assessing the JVD or jugular venous distension, their pulses, are they bounding, or are they easily obliterated when you're taking them? What would that mean if you're taking a pulse and you barely are taking it and it goes and you can't feel it anymore? What could that indicate?
It's a thready pulse.
Thready, but also think about in relation to hypervolemia or hypovolemia, what would you think the person is more likely to be experiencing?
Hypovolemia.
Yeah, good. So here is, and again, this is under normal conditions and normal kidney functioning. For a normal adult, and this is, if increase is specific, you look at specificity. So if the specific gravity for increased, sorry, I'm all of a sudden. I don't know what they're asking here.
Are you asking if urine output is increased, then specific gravity would display as what? Increased or decreased, and then urine color is what? If the output is increased. Is that what it's asking?
Yeah, sorry, this slide I got, yes. So if urine output increased, what would you think the specific gravity should do? And what color would be the urine?
Wouldn't it be decreased if the urine output is increased?
Yeah, and what color would your urine be?
Well, it should be clear, right?
Clear.
Right. Or yeah, that light yellow. And if it's decreased, your specific gravity again would be increased, right? And then your urine color would be what?
More like a darker amber or something.
Yeah, barely. I mean, I've seen some patients where it's barely coming out. Like I don't know. Sometimes I've seen them almost look a dark rust. So, and then these are minimal acceptable urinary outputs for these age groups. Okay,
I'm
so,
going to interrupt, Ms. Thorpe, but it's 11:50. Just want to let you know.
oh, thank you. Okay, let me see, where am I at? Oh, boy, let's see. Let me just hit a couple more slides and then I'll give you 5 minutes and then we'll come back and do the ATI. Measuring output in infants. This is extremely important. And I think those of you who went already into a NICU situation and maybe have even seen them doing this, weighing diapers. So you weigh the diaper, you've zeroed it out compared to what the diaper is. So you hit 0, now it's, and you weigh the diaper. Let's say the diaper is 14 grams, basically 14 mLs of urine output is what you're going to document. Okay, you don't document the grams, you document it in mLs. Let me see. So it's 11:50. Let me just see what more I have here. Okay, let me just go back to. Oops. So let me just cover this because this is going to have some tie into the gastroenteritis one. So for dehydration, there's really 3 different kinds that we look at. Dehydration or fluid loss in excess of fluid intake results most frequently from the gastroenteritis, severe gastroenteritis, and is one of the most common causes of hospitalizations in infancy and children. Decreased fluid intake or increased fluid loss can cause dehydration. And these are the different types of dehydration you could have. All right. So hypertonic dehydration causes are from vomiting and diarrhea and breastfeeding difficulties. So these are things that you could come up against in a baby. You could have if mom's not able to breastfeed well, and we're not giving any other kind of replacement to help with that. Hypertonic IV fluids, tube feedings that have too much sodium in them. These are all going to cause hypertonic dehydration. Okay. I'll just show you these slides. Let's see. So clinical manifestations, decreased level of consciousness, confusion. Basically, the brain cells are shrinking. Dry, swollen tongue, flushed skin, and you will have increased DTRs. Remember what those are? What are DTRs?
Deep tendon reflexes?
Yes, deep tendon reflexes. And you'll be doing those in labor and delivery on patients with preeclampsia. Hypotonic dehydration is usually after severe or prolonged vomiting and diarrhea. And you try to give PO or IV replacement fluids. And this can be caused by irrigating the body cavities with water instead of normal saline. And it's caused also by loss of sodium. So excessive sweating, maybe diuretics, burn patients, or renal disease. And here's the clinical manifestations. Let me see. So isotonic dehydration is the most common. In this situation, basically in this situation, there is electrolytes and fluid going out. So it's kind of equal. That's why it's isotonic. Some of the etiology would be GI tract from vomiting and diarrhea, malabsorption, endocrine system. It could be fever, cystic fibrosis, diabetes mellitus, burns, tachypnea. Why tachypnea? Why do you think tachypnea would be in a situation where they could be dehydrated?
Dehydration can cause low blood pressure, so the heart is trying to compensate for that by increasing the lungs are trying to compensate by increasing respiration.
Yeah, so in what does that increasing respiration, what is that doing?
It's trying to pump more oxygen through the lungs and the body.
I think I'm trying to get at the actual, is actually putting, the person is losing fluid, right? It's called, because they're breathing, their quickness in respirations is causing dehydration. So it's kind of like, what you're saying is right too, but it's kind of like a continual effect. Okay, the rest of this, you guys have this, so I'm going to let you take a file. And I'm going to bring up the ATI and we'll do the ATI, okay? So come back, pardon me?
You put that in Canvas, this PowerPoint? Is it on?
Yeah, it's actually, there is, the student version is in Canvas, yes. I did post it. And we'll just bring up the ATI on my computer. Okay. All right, take a quick break, guys. Is everyone back?
Yes, ma'am.
Yes.
Okay,
Yes.
awesome. All right, so while we're doing this, I think the best way to do this, because is we'll stay as a group, as the whole class. So in order to get more out of this, you know, obviously it's nice to have people really put out there, have a discussion as we're doing this. It's going to ask questions, and then we can put out answers. I could have you do it. What is a good way for us to see? Well, let's see how it goes. It might be that we'll do reactions. Because it's kind of hard to see everything. I can't see you guys anymore. Let's see. But let me get this started. All right.
Hello, this is Susan Brown, RN. Can I help you?
I'm Mary Hall, the clinic nurse.
You can hear it, right?
Yes.
Yes.
Okay.
Transfer Matthew down to the unit.
Okay, I will be the nurse caring for him.
All right, the provider prescribed a stool specimen because of Matthew's diarrhea. I collected that and sent it to the laboratory.
Okay.
I will give you more of a report when I transfer him to the unit.
Great, his room is ready. See you soon.
Bye.
Hi, I'm Mary from the clinic. We spoke earlier today on the phone.
Hi, I'm Susan. Hi, Matthew. I'll be your nurse. Hi, I'm Susan.
I'm Sarah, Matthew's mother. What is all this for?
I'll go over everything and explain what this means for Matthew and for you.
So Nurse Susan is reviewing the isolation prescription for Matthew. Which of the following types of isolation do you think she should implement? And we can go up here to the EMR and got orders. I don't see any orders there. Let me know if you need more time here to look at some of this stuff, but I don't think there's much there right now. So what kind of isolation do you think she's going to implement?
Contact.
Contact.
Contact. Okay. Good. Contact precautions for the clients who have a known or anticipated illness that's transmitted through contact with GI secretions or drainage from skin and wound infections. So good.
Matthew is a 4-year, 2-month-old who arrived in the clinic first thing this morning due to having diarrhea for about 2 days. Is that right?
Yes, 2 days.
Okay.
I'm going to back up here, guys. I want you to try to write an SBAR. Keep some notes and let's talk about it.
Matthew is a 4-year, 2-month-old who arrived in the clinic first thing this morning due to having diarrhea for about 2 days. Is that right?
Yes, 2 days.
Okay, Dr. Irving's going to go ahead and admit him due to dehydration. Yesterday, he really didn't eat or drink much of anything at all. His mother stated that he had a couple sips of apple juice. That was about it. According to the FACES pain scale, he rates his pain level at about a 3. His mother feels, though, that he's just a little more upset than he is in pain. He's current with all of his immunizations. His vital signs today were a slightly elevated temperature of 38 degrees Celsius, pulse of 120, a respiratory rate of 30. He has clear lung sounds throughout. I didn't hear any heart murmurs. He does, however, have hyperactive bowel sounds. He goes to daycare full-time. He's potty trained, but due to the diarrhea, his mother has placed him in diaper briefs. The provider already entered the admitting prescriptions into the computer. Do you have any questions?
No, thanks for the report.
Yeah.
Okay, so this is where, let's have you, who wants to, maybe I can do it. Okay. Tell me the situation.
4-year-old having diarrhea for 2 days.
Diarrhea. I know I spelled that wrong. Okay. Should we go to background or do you want to put any more there?
I would add the admission reason, so admitted to pediatric unit for dehydration.
3-year-old. For dehydration. Okay. So what about background now? Do you want to add any more there or start with her background?
Background.
Okay. What do you think?
You can list the vital signs. You can list that he's up to date on his immunizations, that the mother put him in briefs related to his diarrhea, that he has no murmurs.
So so for the assessment, I think a lot of that would go in assessment, right? But the background, yeah, the
We can put his full-time daycare and his potty training.
he is potty trained, right? She just put him in a diaper because, or what did they say fully?
They said he is potty trained, but he's wearing a brief because of the diarrhea.
What about food intake?
He has a poor appetite, I believe.
And I think she said has only had apple juice, right?
All right.
What's that?
Is that not going to make the diarrhea worse?
He probably, yes. Good point. What else? Do you want to put anything more on background? How about was in the doc? Seen in MD office. And they said did they do lab work there? Did they say they did lab work? That's where I would put, you could put in lab work drawn prior to, if that's what there, okay? And then assessment. What were all the assessment parts that you guys would add?
That would be like the vitals. So it was the temperature 38 degrees Celsius. Pulse was 120. Respiratory rate 30. And then she said clear lungs, no murmur, and hyperactive bowel sounds.
Clear lungs. Oh, no murmurs. And then what did she give any recommendations, or do you have any?
Oh, one more thing was that he was a 3 on the FACES pain scale.
Oh, yeah. Oops. But she said that mother states he's more irritated or frustrated, or
She said upset as opposed to in pain, right?
Yeah.
yeah. Thinking about developmental, why do you think upset? Not only because he doesn't feel good, but what else?
Definitely does not want to be in diapers again.
No, that's what I would think too. Yeah, the diaper situation is going to get him frustrated. And so what would be recommendations?
Can you click the EMR? I don't know if there's any
Yes.
order for.
Yep. What do you want to look at? Let's see. That doesn't look like that's even got anything yet.
Is there any?
Here's the orders.
Yeah. Okay, so he's already on IV fluids.
Well, these are our orders, so she's going to have to do these. But we do know the labs, the CBC, BMP, which what does the BMP stand for? What is that going to give us?
It'll list any imbalances and electrolytes related to dehydration.
Right, good.
Is there any culture sensitivity on there?
Yeah, I would have. Most of the time, like if you were taking this from the hospital, if they were going to poke this little guy anyways, that would be a nursing thing. You could say, do you want to go ahead and do a blood culture at this point? Because what do we know if this were to get worse? What could happen if this gets more severe? I think septicemia is one of the things, right? So let's look, but I thought I saw somewhere, here we go. Does that give you enough information there? Are you guys good? So if we go back here, I think what we're going to address in recommendations is most likely we're going to address what we need to do next, right?
Would you recommend a stool sample if he's still having the diarrhea, just to rule other things out?
Did they order that? Let's see. May have, oops. Daily weights. It doesn't say, but that might be something later you could call the doctor with. Like if you got a stool, you could save it and then call the doctor. So recommendations would be, if he's dehydrated, we may want to get some sort of diet ordered. So maybe we could say we would, shoot, what the heck? Really? Oh. Did that just knock us completely out? Gosh darn it. Okay, sorry guys. Lovely, huh? Sorry, I'll just go real quick through this and then we can.
Hello, this is Susan Brown.
Matthew is a 4-year, 2-month-old. Paper briefs. The provider already entered the admitting prescriptions into the computer. Do you have any questions?
No, thanks for the report.
Yeah.
Okay, we're not going to rewrite that all, but the only thing we would put there, I think, need to be, let's see what they put. So they put, like you guys said, the 4-year-old with dehydration. The client came back to the clinic this morning having diarrhea for 2 days. So we pretty much got that part. The assessment we had. The only recommendations was admitting prescriptions for the hospital are on the computer. I don't know. I think I'd put a little more, but all right. So
I'll be Matthew's nurse until 7 o'clock tonight. How should I address you?
Sarah's fine.
Okay, let me explain why there is a cart outside the room and why I'm wearing this gown and the gloves. Because Matthew's had diarrhea, it could be infectious. We won't know for sure until the report is back from the laboratory. The gown and gloves help prevent the spread of a possible infection to other hospital clients and for protection of the hospital staff.
Okay.
So it seems like you've had a pretty busy past few days with Matthew. Has he been having an elevated temperature at home at all?
I'm not sure. I don't have a thermometer. I'm a single parent, and I don't get any help from his father.
Okay. Would it maybe help if you spoke with a social worker to help with some possible financial issues that could occur due to the hospitalization?
I'll think about it and let you know later.
Okay. First, what I'd like to do is an assessment of Matthew. He could sit in your lap for most of it or in bed.
He should do well on the bed. Matthew, the nurse is going to listen to your heart now. Is that okay?
Okay, Matthew, I'm going to give you a little ride up in the bed. After this gets up a little bit, I'm going to listen to your heart and to your tummy. This is my blue stethoscope, and what I get to do first is clean it. After it's all clean, I'll be able to listen up to you. We want to do this to make sure there's no germs on it. Okay, can you pull your shirt up? Thank you. You've done this earlier today, haven't you?
I've done it a whole bunch of times.
Oh, good. Good work. You can keep your shirt up. I'm going to listen to your lungs now. And what I could have you help me with is taking deep breaths through your mouth, okay? So like this. Deep breath for me. And another one. And another. And another. Good work. I'm going to have you sit up and I'm going to listen to the back of your lungs too, okay? Thank you. Perfect. I'm going to pull your shirt up back here too. More deep breaths. Another one. Another one. Okay, go ahead and lie back down. We'll pull your shirt down too. Sorry. Okay, I'm going to listen to your tummy now. Can I have your shirt up again, please? Thank you. Here's your track. Okay, I'm going to turn my machine over here on. And this will give us more information to see how you're feeling. Good work. Can you pull your sleeve up there? Thank you. I'm going to pull this up just a little bit more. Can I come under? Thank you. Okay, and we're just going to relax it here. Good work. This one is like a little alligator, and see it has a little red light in there? We're going to put our finger in here like this, okay? You did this earlier probably too. We're all done with this part, Matthew. His respirations were 30. He's not feeling well, is he?
No, not at all.
Can you point to the face on this chart that shows how much your tummy hurts?
I'll change you.
Here, let me get you a few extra diaper briefs. The provider wrote to keep track of the intake and output. So how we do that here is each time you have a soiled diaper, we weigh it so we can keep track. If I'm not in the room, go ahead and put the soiled diaper briefs over by the diaper scale, and I'll weigh him when I come back in.
Okay, he really has a bad diaper rash. When I use the diaper wipes, it burns him. Would it be okay if I used a washcloth instead?
Yeah, that's fine. Let me get one for you. They're right over in this cabinet, so feel free to help yourself. I just need to go enter this information in the computer. I'm going to get you lowered back down here, Matthew.
Okay, so Nurse Susan completes the admission assessment. Matthew, which of the following is a priority action based on the assessment? What do you guys think?
Initiate IV access, maybe?
Does that sound good, guys?
Yeah, I think so too.
Yeah.
Yeah.
Why are you thinking that?
He's not vomiting and he didn't have a fever.
Okay, Good.
If his respirations are high, then maybe he's dehydrated. So IV access would give you access to giving him fluids.
Perfect. Okay. Let's see what it, yep. So rehydration is the primary goal for the client who's dehydrated, and oral replacement is not an option for the client because he's vomiting. Are you guys doing okay with this?
Yeah.
Okay.
Hi, Susan.
Hi.
What are you doing?
Well, I need to start an IV catheter on my newly admitted client, Matthew.
Okay. Do you need any help with that?
Nope, I think I've got it. But thanks, Peter.
That was fast. Okay, so this is where she's gathering supplies to insert the IV catheter for a saline lock. The IV start kit contains a tourniquet, antiseptic pad, 1-inch paper tape, and transparent dressing. Which of the following images includes the additional supplies she should obtain? So just, I'll show you all of them and then you can, let's see. So what is this here?
That's the primary tubing, isn't it?
Yeah, does she need that right now?
No. It's a saline lock, right?
Right. How about this? So again, we probably don't need that. What size catheter do you think we need?
(22 to 24).
Yeah, 22 is kind of big, but maybe, but still, are we thinking we don't need that IV tubing? And then, so they're only going up here. So what about, she's got sterile gloves, IV tubing. Look at the size of this arm board. Is this anything that we would think she needs?
No.
Yeah, I don't think so either. All right, this one has smaller gauges, but I'm not sure. What do you think? There's a lot of stuff here. So which one do you think? We have this one. We said no because of that.
Are they suggesting larger catheter size for a fluid bolus?
I mean, no, 20 gauge I think would be too big for a child. 22 to 24 would be okay. I like to go a smaller in this situation, but 22 is okay also. But I think out of these, gosh, she puts tubing on each one though. So what do you think? Out of these three?
I like,
again, or?
I like B, but at the same time, D would be, I mean, a smaller gauge. And then for some reason, if there's something wrong with the tubing, it's always nice to have an extra, you know, extra stuff just in case, because you're dealing with a pediatric patient. You don't want to have to like do it again or leave and come back, and you want to be prepared. So
okay, so what else do we know though about bringing stuff into the room in this situation?
Yeah, I was thinking about that because I chose B because as far as B is concerned, we have a lot of stuff. Or since the kid is on isolation, you take it inside, and then if you don't use it, it's a waste.
That's what I'm kind of thinking. Was that Nozomi or who was that?
Armel.
Armel. That Shannon was who else was speaking, right? Okay. Armel is, I think you guys are right, the ones that are thinking B, but let's see, okay? Let's say B. So yes, and I think that the reason is basically you will use this tubing because you're going to get fluid. Right now you're just doing the INT, the saline lock. So 3 catheters is kind of a lot, but you know, you could leave it in there for it would just get left in there. You wouldn't bring it back out.
I have Matthew's IV fluids here, and I'm just going to get prepared to administer.
What for?
They're to help correct the dehydration. I just need to scan them in the computer, and then Matthew, I'm going to scan your armband. Okay, Matthew. Oh, thank you. Perfect. And what's your name?
Matthew Daniels.
Yeah, and what's your date of birth, your birthday?
June 10th.
And how old are you?
4 years old.
You are such a big 4-year-old and so smart. Okay, Matthew, can I see this hand? Thank you. I'm just going to use this little piece of tubing to help me, okay? No, it's not going to hurt, but if it does hurt, you're going to tell me, okay? Let me just get this prepared to administer and program the pump.
So Nurse Susan is caring for Matthew, who is receiving IV fluids using a infusion pump. Which of the following is the correct rate of flow for the IV solution? You want to go back to the EMR? So it says to give 200 mLs over 90 minutes. So what would be, what do you think?
Calculation says 133 an hour.
That's what you calculate? Everybody agree?
Yes.
Okay. Is that how, yep. Okay. Good.
I just administered the IV fluids. The provider prescribed to have them infuse over 90 minutes.
Okay.
Is there anything else you need?
No, I don't think so.
Okay, I'll check back with you in a little bit, Matthew. Okay, the bag of IV fluid is complete, so I'll get the regular IV fluid started.
Oh, good. The machine has been beeping.
Okay, let me just get this scanned into the computer and scan Matthew's armband, and then I'll be able to get this infusing.
Oops.
Can I see your armband? Thank you. And what's your name?
Matthew Daniels.
And when's your birthday?
June 10th.
And tell her how old you are.
4 years old.
Oh, thank you. Okay, I'm just gonna get your other bag going here.
Then is it gonna go in here?
Yeah, but it shouldn't hurt. Okay. Okay, let me see. Does this hurt at all?
No.
Good. So Matthew, I'm just gonna raise you up in bed and we're gonna do a little bit of an assessment again, okay? I'm gonna listen to your heart and your tummy and then use my machine to see how you're doing.
I know what you're saying.
You do?
It's the thing it wraps on.
Yeah, good. I'm gonna wrap that back on you, okay?
Iron machine.
Does he still have a fever?
Yes, he does. Has he had anything to eat or drink?
He did finish this entire thing of apple juice before you came back.
4 ounces. Well, that's good.
Well, I don't know. His tummy hurts.
Well, it might hurt a little bit just because he hasn't had anything to eat or drink for a while, but it shouldn't get too bad. If it gets worse, please let me know.
I will. Also, I changed him 3 times and put the diapers over by the scale.
Okay.
He's having very watery diarrhea still.
Is his bottom still red?
Yes.
Okay. I'll bring the diaper cream in next time. I'm just gonna weigh these diapers and get all of this information put in the computer. Okay, 52. 26. And 33.
So she's gonna document his intake and output. What, I guess first figure out what you want to put. What's his intake? She said that was a 4 ounce juice. So what would that be?
120 milliliters.
120. And then how much output? It was like 52, 26, and 33 is what I got. So the IV fluid going in was how much?
And 133 mLs an hour.
Yeah, so total, I think it was 200, right? 200 mLs. So does this look right? I don't remember them saying he had an emesis.
No.
And is he going through the urinal?
No.
No, okay. All right, here's this. Still urinal is there. And 300 IV. Sorry, guys, I'm kind of moving through this so we can get to. Got the IV right and the PO right. Are you seeing this? Okay. Interesting. They're still putting urinal, but I don't remember them saying anything about the urinal, but I think this is the closest one, isn't it?
This one, isn't that saying emesis though?
Yeah, I know, and they didn't say anything about that.
And this one also says green. I don't remember the mom saying green, just watery.
Just watery.
But I don't.
But remember, the nurse is gonna do this because she's looking at the diapers. Let's see here.
They all say MS is weird.
I'd say the last one's the closest because it has the 3 watery stools and the 120.
Yeah, so those two, I don't think these two for sure are not right. So you're saying it's between this one. See, technically, when she's weighing the diaper, she's got both urine and stool there. And then here, she's just calling it stool. So which one do you want to go with? What do you think?
D.
You want to go with D? Okay. Yes, that was correct. So if you look back at that, they did divide it out. Now I have to tell you with babies, but he is 4, so let's see here.
Hello, is your nurse in the room?
Yes, I'm here. This is Susan.
You have a call on line 2.
Okay, thank you. I'll be right out. Sarah, I need to go take this phone call, but I'll be back in just a few minutes. Are you okay?
Yes, thank you.
Hi, Ms. Daniels. I'm Dr. Wilson, the resident provider here at the hospital. I'll be involved in Matthew's care. I see he's sleeping now. I won't bother him, but do you have a few minutes to talk?
Yes.
Okay, maybe you could tell me a little bit about him and what's brought you here today.
Well, he started having diarrhea about 2 days ago, and he's not eating or drinking anything, and Dr. Irving says that he's dehydrated.
Okay, and how is he today?
Well, he vomited once when we got here, but he hasn't vomited since. He's running a temperature, and he's so irritable. He's had 4 diapers, all with diarrhea, since we came. He hasn't eaten anything, but he did finish a cup of juice, and the nurse gave him an IV. She started a bag of IV fluids, so I think that's helping, but he's still complaining that his tummy hurts.
Would you excuse me for a moment?
Sure.
Hi, this is Susan Brown, RN.
This is Tom Smith from the laboratory, and I'm calling in results for your client, Matthew Daniels. I also put them in the computer.
Okay, so let's look at his labs. So sodium is 136. We said bottom line today, what did we say, 135?
Yeah.
And what about potassium? What does that look like?
It's super low.
Yeah. So when you come back over here, which of the following would be a priority action for her?
Potassium.
For potassium, yep. Good.
Dr. Wilson, the laboratory just called about Matthew Daniels' test results, and I was going to call you to discuss new prescriptions. I have the lab results up on the computer now.
Matthew's having multiple loose stools, low-grade fever, abdominal pain, vomiting, and now these altered laboratory test results. Susan, I'm going to make some changes to his plan of care. Just call me with any questions.
So after he changes the prescription, Susan is preparing to administer IV potassium, which is the following is the correct technique. Administer an IV bolus of undiluted potassium chloride solution over 3 to 5 minutes. Is that right?
Definitely not.
Okay. Add 5 of the undiluted potassium to his maintenance IV solution. Is that right? What do you think?
Can we look at the EMR real quick?
Yes. Okay.
Last one.
And I have to point something out here. This would no longer be ordered. That's why I put the other one, the Zofran, in your med templates. But the potassium is ordered 5 milliequivalents in 100 mLs, given as a one-time bolus right now. And then it looks like we're going to do a serum potassium after the infusion is complete. So going back here, which one would you want to put then?
C.
See? You guys are good. I know we're getting close to, you want me to keep going or?
Matthew's potassium levels are low. Dr. Wilson prescribed some potassium chloride solution that I will administer through the IV tubing. I have it with me now.
Do you have to wake him up to give it?
No, it will be infusing through the IV tubing at the same time as the maintenance IV fluids. This will take 1 hour to infuse. However, I do need to attach these pads to Matthew. We'll be able to use the monitor to keep track of the heart rate and rhythm as we administer the medication. But I'll be careful not to wake him.
Okay, good. I just don't want him to wake up early from his nap. He hasn't been sleeping very well and he is overly tired.
Okay, I'm done. The medication is infusing.
Great.
Here's the clotrimazole cream that Dr. Wilson prescribed. You can use this for the rash on Matthew's bottom.
Oh, okay. I've never used this before. I don't know anything about this cream.
So dry, what would you want to put about the Lotrimin? You can look back on the EHR. Are you guys still with me?
Yes.
Yes.
Don't you just apply a thin layer of the medication twice a day?
You know, it doesn't give you, so the rest of them, this is how I would look at it. I think I would put that the one, but it says,
Wouldn't you dry the skin thoroughly before you apply any type of cream? So maybe the first one?
you want to go with the first one?
I don't know. What does everyone else think?
Yeah, I know.
A bunch of comments in chat agree with A.
With A? Okay, we'll go with A. Good.
My apologies, Miss Thorpe, but there's some of us with our out rotations that have a Zoom meeting in about 6 minutes. Is there anything else we need?
No, this was, I can keep going on this if you guys want me to, or we can stop. What do you want to do? No, we're, as far as this, I was just going to finish up on this. Remember the templates and then think about the methods sheet, what you would be teaching this mom after. You can get into this yourself too. It's in your student, you know, in your area too.
So
all right.
Are we just turning in what all do we have to turn in? The templates and then something for the methods, or are we not doing the methods now?
Yeah, turn in the methods. Then turn in your template. You finish those templates. That would be the assignments that you would turn in. Yeah.
And for those of us who haven't done the methods before, are we just basically filling out a sheet based on like what those methods, what that form says?
What I would do, Shannon, I would go back to, we'll take into assessment what this mom is like and what she's already told us. We do want to go back and address that she's a single mom and she doesn't have a lot of support, right? But then go back to the ATI book, had a lot of patient education materials, you know, or suggestions in there. And just follow that. If you need help, just let me know and we can go over that.
Okay, thanks.
Do you want me to keep going or is everybody ready to go? It's okay, whatever.
How many methods are we doing? 2?
Just, well, the methods is just a teaching sheet. I mean, I think of it as this is what you're gonna discharge teaching for this mom once the child's ready to go home. So what medications do you think he'll go home on? If any, right? I mean, offhand, I would think maybe they would send him home with some antiemetic, like the Zofran, the diaper cream, right? And then what follow-up appointments do you think he should have? Any labs, if anything?
Okay.
All right. So am I going on or you guys are ready to go?
We are ready to go.
Okay.
The silence says it all.
I know, that's what I don't want to just stop if you guys are okay. Okay. All right, no problem. I think actually you get the idea of this, right? And if you want to go in there and follow through, I think they go a little more into with the mom, getting her some help. I think this is one where they have a little disagreement. There might be a disagreement with the doctor in here or something, but it's pretty close to getting done. Okay.
Okay.
All right, guys. Thank you for being so patient.
Thank you. Hey, Ms. Thorpe, I had a quick question.
Yeah.
On Friday, you know how we're split up into groups and stuff, and the assignment we did in groups. I noticed that on mine and my other peers' grading, you said it didn't go through. You left the message, did it?
I think I couldn't open it. Was it in Pages?
I'm not sure how Roberto submitted it. I think it was through Google Docs, or I'm not quite sure, but.
Oh, the ones I said I couldn't, it was just that I couldn't open it. So do you want to go back and look at it and just let me know if I'm just need to do something different?
Okay, I'll check it out.
Okay. All right. Thanks, guys.
All right, thank you. Have a great day.
You too. Have fun in clinical. See you guys, whoever I have. Okay. Bye.